I'm going to spend some time this morning and go through the Patient Protection and Affordable Care Act, and I'm going to highlight accountable care organizations. I am going to breeze through this presentation. If anybody wants it, Dr. Combs is already looking at his watch. I'm notorious for filling in the largest amount of time possible, so I'm going to try and keep it similar to last night. It's never identical. If you do want the presentation at the end, let me know, let Mr. Rhodes know, and we'll give you the presentation. The Patient Protection and Affordable Care Act, the goal of it is to expand access while seeking to improve quality and contain the growth of health care spending. So we want to improve quality, improve access, but we also want to decrease the rate of growth. The goals really are not consistent. When you look at it, and the number I use is 32 million people are added to the ranks of the insured, whether it be a public insurance program or a private insurance program. That number actually, you see, it can be as high as 40 million people. When you look at it, if we're going to try and control the rate of growth, but yet we're going to expand access and coverage to an additional 32 million people, we do have some issues. There are new public programs that have been established, and I'll talk a little bit about some of those, and new coverage mandates have been imposed. Some of those coverage mandates increase the number of covered services. Today, for the first time, effective January 1, Medicare actually covers wellness visits for beneficiaries and a large number of preventative medicine services that have never been covered before. So we've expanded coverage, which by the very nature is going to increase cost, and we've also increased the number of participants who are in the health care program. Really not a recipe for cost containment. In the past, Medicare has tried to slow the rate of growth down by cutting reimbursement rates. This one I know I said last night because I say it every time I talk about Medicare. It is the only business I know where, starting in September of the year, we keep our fingers crossed that our reimbursement for identical services will not be cut. And we always hope that our reimbursement will remain the same. But even with those cuts in Medicare over the last 10 plus years, the rate of growth has not been slowed very dramatically at all, if at all. So, success of healthcare reform depends upon transforming the system. And the interesting part about healthcare is we don't transform very quickly, nor do we like change very well. What this act sets out to do is reform payment methodologies, improve quality of care, and to truly try and transform the delivery of services to Medicare beneficiaries. Today, a physician or a non-physician provider applies to participate in Medicare, and unless they've been disbarred or done something terrible, they are accepted as participating provider. Medicare through ACOs and healthcare reform will begin to screen physicians and non-physician providers much more rigorously. And part of what they're going to look at is quality, but also cost. More costly providers may have issues long-term staying in the Medicare participating provider network. Over the last few years, those of you who have followed electronic health records, you will realize that Medicare has done a number of things to incentivize physicians, hospitals, and other healthcare providers to institute electronic health records. And with that, there are incentives. Some of those incentives can be as much as $44,000 per year, up to $68,000 per year for eligible professionals. That's for a defined period of time. 2, e-prescribe. There is a bonus which physicians can receive and non-physician providers if you're eligible for the ability or for electronically prescribing. And that really is electronic from the physician to electronic to the pharmacy. Those incentives are in place for a number of years, and then disincentives begin if you're not doing it. PQRS is a quality reporting system that CMS instituted a number of years ago. We are actually, EVMS Health Services, on our 4th year of submitting data. They are quality indicators in all specialties, and if you submit quality indicators and you meet the indicators you submit, you are eligible for a bonus. That bonus varies in size. The largest one that we've received to date is a little over $60,000. Really doesn't come close to covering your infrastructure costs, but you can see that there is a lot of incentives from Medicare to begin to get onto an electronic health record and to use it to improve quality of care. Sunshine laws, I always have to stick this one in. We do a lot of agreements with drug companies and with device manufacturers. And you can see here that starting in 2013, these companies are going to have to report to the government physicians who have received payments from the company. And part of what you can figure that they're driving at is if you're being paid by a certain drug device manufacturer, what is your practice pattern like? Are you using just solely their device? Are you using other devices? And so they're beginning to look at all aspects of healthcare to see if they can change behavior and drive costs down. Patient-centered medical home. This is really a precursor, if you like, to an accountable care organization. There are 2 types, a primary care, patient-centered medical home, and a chronic disease model. It really is a model of care that moves from episodic based on illnesses and patient complaints to a coordinated interdisciplinary team, interprofessional system. The goal here really is to incentivize population management, something we don't do very well in physician practices. And what do I mean by population management? Diabetic patient today, we tend to try and get them to have certain diagnostic tests before they come in. They come in and we look at those and we then give them a treatment plan, which is usually verbal. And we say, you know, we think you need to meet with the dietitian. You need to enter into an exercise program. You need to do this and you need to do that. And today what usually happens is we usually don't do very much about that until the patient comes in 6 months later for their follow-up visit. In population management, there is a caseworker who is responsible for following up with that individual on a very timely basis and trying to ensure that they actually have followed the directions of the physician and have gone through with some of those lifestyle improvements. Issue with that type of care today is it's unreimbursable. It increases infrastructure costs but does not increase revenue. And there are some models out there that actually look at paying a certain amount per month for the insured members that a patient-centered medical home has. We actually have 3 practices today that have applied and are in the process of being certified as a patient-centered medical home through NCQA. We are beginning to look at a chronic disease model, and hopefully we'll have one of those applications in the near future. Bundled payments. This is for the surgical people. This is another program that Medicare is in the process of instituting. And what it really is going to do is provide incentives for care delivery to reduce cost in order to increase margins. Basically, what that means is for a certain surgical procedure, today the hospital gets paid, the physician gets paid, the radiologist gets paid, and all of them get paid separately. Bundled payments are going to lump the payment all into one payment. It will be X number of dollars for that service, and then all of the various constituents involved in that service will get to negotiate who gets what out of the bundled payments. And the idea is so that everybody is working together, hopefully reducing costs. Readmission reduction program. Idea behind it is to reduce payments for readmissions and to try and incentivize people to keep hospital readmissions as low as possible. One of the things that many insurance companies are beginning to look at today is, do physicians see patients within a defined period of time after they've been discharged from the hospital? Many instances today, what happens is, if my physician even knows I'm in the hospital, chances are, unless I call and make an appointment, I may not be seen until my regular visit was scheduled somewhere down the road. Goal here is to probably get these individuals in within 7 days and to manage their care in a more proactive fashion. Hospital-acquired conditions, always been an issue for inpatient care, but beginning in the spring of 2015, Medicare is going to reduce payments to hospitals and physicians for hospital-acquired conditions. Hospitals spend a lot of time these days on protocols and procedures to try and reduce these conditions, but there will be even more incentive for them to make sure that they can keep them down as low as possible, even to the extent that Medicare is going to produce a public website, and that website will rate hospitals based upon their order, if you like, or rank with hospital-acquired conditions. That will allow patients to do a little research ahead of time, and if one hospital has significantly more of these conditions than another, it may actually drive patients to the facility that has a lower rate. Now to what they actually asked me to talk about, which is called the Medicare Shared Savings Program. All of the programs that I talked about previously, by the way, are separate, identifiable programs. An ACO is basically a program that the Secretary of Health and Human Services is required to establish by January 1, 2012, and it promotes the accountability, and that's a key word, the accountability for a patient population, and coordinates items and services under Part A and Part B of Medicare, and encourages investment in infrastructure, there's your EHR and some of your personnel, and redesign care processes for high quality and cost-efficient care. Part A and Part B, for those of you that aren't familiar with Medicare, are, you can really look at them easily as Part A is hospital services, Part B is physician services. There is a Part C and a Part D Medicare as well. Part D is medication or pharmacy services, and Part C is managed care services. Anybody in a managed care program with Medicare at this point in time cannot participate in an ACO. What this allows is for groups of providers to work together, and in some instances, many of these groupings have been very difficult because of legal constraints to put together, and currently are, by the way. I must tell you that the ACO legislation was passed. A lot of what you see here is actually out of the act that was passed. There is a lot of work to do still in terms of the actual mechanical details and some revisions to the legal system as well to make this legal. But you obviously can put professionals who are in the same group practice. We've been able to do that for years. There's not an issue. This also does allow a network of individual practices. So you literally could go out there and network with individual practices that have no legal relationship today, no financial relationship, put them under an umbrella of an ACO, and you then can refer patients back and forth without any issues. You also, one of the things that has been very heavily regulated up to this point is joint ventures and with hospitals and physicians. Those are also acceptable under the accountable care organization model. In order to participate, Medicare requires a minimum term of 3 years. So if an organization decides they want to be an accountable care organization, they have to make that decision for at least a 3-year period of time. Within that, there have to be enough primary care physicians in the ACO to be able to, at minimum, look after 5,000 Medicare beneficiaries. That number was derived at more from an actuarial standpoint, but it's believed to be the minimum number of people that will make the ACO economically viable. On the other side, I should tell you that many commercial insurance companies are experimenting with accountable care concepts. Anthem, which really is operated by a company called WellPoint, has a number of pilot programs out in California. Their population, the commercial insurance population, tends to be a lower utilizer of health services compared to Medicare beneficiaries. And in at least that commercial insurance company, there have to be a minimum of 15,000 of their members. And again, that actuarially is just a number looking at their population and utilization of resources that they deem would be viable for an accountable care organization. Initially, the ACO is going to have to do a significant amount of reporting, and the professionals who are members of the ACO have to be pre-approved by Medicare in order to participate in an ACO. Basically, you can see that the key to an ACO is evidence-based medicine, patient engagement, reporting on quality and cost measures, coordination of care, and that coordination of care can be through things that today are basically non-reimbursable. Telehealth, remote patient monitoring. There are a number of electronically enhanced ways that an ACO will be able to coordinate and monitor healthcare. ACO has to be patient-centered. The patient has to be, if you like, at the hub of the wheel, and the healthcare team surrounds the patient and is involved in coordinating the care. Measures to assess quality. Well, the Secretary of Health and Human Services is going to determine those, but we know that they will be along the lines of clinical processes and outcomes. We believe today that most of that will be very similar to what the physician quality reporting system looks like. Patient and, where practical, caregiver experience of care. There will be a level of patient satisfaction and patient surveys involved in the quality indicators, and some form of utilization. ACO has to submit data, which is similar to what we do today for the PQRS system. And the data is going to not only have to deal with outpatient and inpatient experiences, but it's also going to have to look at care transitions across healthcare settings, something today that we have difficulty doing. One of the things that is going to be critical in order for us to do this is to interface electronic health records with hospital systems. I will tell you that we are probably 9 months away from interfacing ours with the Centera Epic system, and that's really driven because Centera needs to do this as well as we do, plus some of the meaningful use requirements that they have to meet. The quality indicators. Every indication today says that what the quality indicators, the level and the types that are established in the beginning, will not stay constant over the course of the program. It appears that these standards are going to get higher and higher and more of them, and the goal is to demonstrate improved quality each year and reduce cost savings. The PQRS, the meaningful use, e-prescribe incentives I talked about earlier are not part of the shared savings program in an ACO. You need those things in order to be an effective ACO, but the payments actually are separate. There are some providers that can't participate in an ACO because they've been in pilot or beta pilot programs. The interesting part is we're not really sure how beneficiaries will be assigned to an ACO, but we do believe that it's going to be driven by primary care providers. And the current thought is that if a primary care provider is in an ACO and they have a number of Medicare fee-for-service beneficiaries that they are looking after as their primary care physician, that those beneficiaries will be in that ACO. EVMS Health Services has about 13,000 Medicare beneficiaries, so we certainly meet the minimum standard to be a freestanding ACO. One of the misconceptions also is that a hospital has to be part of an ACO. That is not correct. Obviously, hospital services are involved in patient care, but in the initial part of this program, the hospital facility charges would not be counted in the financial activities of the ACO. How are payments going to be made? Initially, physicians will be paid Medicare fee-for-service right off the fee schedule, and then there's going to be a benchmark or a target set by the Secretary of Health and Human Services for each ACO, and that's really based upon prior 3-year experience for the members, the beneficiaries in that ACO. And then there is going to be, well, if we think that the target is 4%, we want you to hit 3%. And that 3% is actually the shared savings, which will be split, if you like, between the ACO and the government. Pilot programs today that have occurred with CMS, there is one large pilot project that had 5 very large physician groups. One of them had over 300 physicians. Over their period of time in the pilot program, that ACO, the total savings was $38 million. The ACO received 80% of that $38 million, or a little over $31 million. So this is where I always say, people say, well, healthcare reform might get repealed, it might be changed. And you know, whether that occurs or not, I will promise you that the ACO concept will be implemented by Medicare. It is the only thing they have seen to date that actually can reduce the growth in spending for Medicare beneficiaries. We know in our world that Medicare does something, and then on a 3 to 5 year period of time, all the commercial payers tend to follow suit. So this concept, we believe, is actually going to radically change the way we deliver health care, and really incentivizes primary care physicians to get more involved in the coordination of care of their patients. More primary care physicians there are in an ACO, probably the greater likelihood there will be to be able to coordinate that care and to achieve cost savings.
Good morning. For those of y'all that don't know me, my name is Linda Arch. I'm the Associate Dean for Graduate Medical Education here at the medical school, and my task this morning is to share with you all some of the changes that are going on in GME that will have an impact on us here at EVMS. Two kind of side notes kind of related to Jim's presentation is one of which is that while finance doesn't like changes, the regulatory bodies in graduate medical education love change. So we're dealing with change constantly. The other thing is that it'll be interesting to watch over the next couple of years how the movement to ACOs affects the recruitment and interest of medical students in primary care programs, because we go through kind of peaks and valleys with primary care. We're kind of in a valley right now, so with some of these new incentives, there may be a resurgence of interest. Okay. For those of y'all who aren't involved in the actual medical education process, graduate medical education is the second phase in the professional training of physicians. So medical school is the first phase, GME is the second phase, and we basically have 3 levels. One is internship, which is a 1-year program, which is a preliminary to going into a different specialty. For example, dermatology requires 1 year of medicine prior to going into dermatology. We also provide core residency training programs, which are those which provide the initial board certification like internal medicine, OB, family medicine. And then we also have fellowships, which are the subspecialty training that most of the time require completion of a core program before going into fellowship. For example, cardiology, you have to complete an internal medicine residency before going into cardiology. At EVMS, we also have a psychology internship, which is a 1-year clinical requirement for PhD and PsyD psychology majors and PhD programs. Graduate, and we're going to focus on the MD programs because that's where the major changes are coming that are going to impact us. The GME programs are accredited by the Accreditation Council for Graduate Medical Education. Without accreditation, if a resident well, there really aren't any, but if a resident would say go into a non-accredited program, they couldn't sit for their board. So it's very important that we maintain accreditation. The Accreditation Council has 3 levels of accreditation. One is institutional, which is the oversight of what my function is here at the medical school. If I don't meet my functions, we can't have residency training programs. So they come and visit me about every 5 years. Our next accreditation will be January of 2012, which is why these changes that are going to occur July 1 are going to be very important for us to be able to accomplish. They also have what they call common program requirements, and those are requirements that doesn't matter if you're a pediatrician, a surgeon, a plastic surgeon, vascular surgeon, an obstetrician, we have to meet those requirements. These are the ones that are changing as of July 1, so they're going to have a substantial impact on the entire training program. Then they also have specialty requirements, so each specialty has a residency review committee that establishes requirements that those particular programs must meet. In November of this year, I attended the Association of American Medical Colleges conference in DC, also attended the group on resident affairs, which is my professional organization, and Dr. Tom Naska, who's the CEO of the Accreditation Council, provided the plenary address. Basically what he talked about is there's a revolution in GME, and come July 1 of 2011, they're going to arm us with our weapons, which are going to be changes in supervision and changes in duty hours, as well as some educational changes, and that the basic tenets of this revolution is that residents are learners. The care that they provide is secondary to the relationship that they have as learners, and that we as medical education institutions must establish and make sure that the learning environment in which the residents train stress that and provide safe and appropriate patient care. So he kind of said to us, go forth and make change. And as we walked out the door, he basically said, but I got a quote for you, which is that faced with choice between changing one's mind and proving there's no need to do so, almost everybody gets busy on the proof. So to expect a lot of resistance, and in fact, we've known that these changes were coming. There has been a lot of resistance, but we're kind of, if you look at the Kubler-Ross stages of grief, we're kind of into the acceptance phase and we're starting to move forward. Now, why are we at this revolution? It's been a long time in coming. Some of you all may remember the Libby Zion case back in 1984. Libby Zion was a young woman who, excuse me, went to the ER and 24 hours later was dead. Her dad was not only an attorney, but was also an investigative reporter for the New York Times and did his own investigation as to what happened to my daughter. What he found was that her care was being provided by a first-year physician. The supervisors for that first-year physician were asleep, and she never went to awaken them and call them for care. She was caring for a very large number of patients, and she'd been on service for, I believe it was almost 36 hours. So armed with this information, Mr. Zion brought this to the attention of the community. This resulted in the formation of the Bell Commission, which was looking at graduate medical education. They came up with some recommendations to the ACGME that we needed to better oversee duty hours, we needed to provide more structure. ACGME implemented these, and that's why we're with the 80-hour work week that we are now. In 2008, the Institute of Medicine, looking at a number of looking at a lot of information, determined that really ACGME was not monitoring duty hours very well. We had violations all over the place, non-compliances, and they made a lot of recommendations, one of which was that because ACGME wasn't monitoring very well, let's bring the feds in, let's get Medicare in to come in and monitor these, or OSHA, or somebody that's got some clout. There's one thing ACGME did not want. It was more federal oversight of their management functions for GME. So they established what they call the ACGME Duty Hours Task Force to look at some of these concerns and establish more regulatory oversight. And as we go through this, you're going to see that they went way beyond duty hours when they came back with their recommendations, which are the recommendations that are going to become basically requirements in 2011, July 1 of 2011. In 2010, there was a civic group as well as a resident union that filed a petition with OSHA to come in and oversee graduate medical education as a workplace safety issue, and so far OSHA's not really willing to do that. So what did the ACGME Resident Duty Hours Task Force do? And this is directly out of the report. They were to prepare a comprehensive package of interrelated standards that would assure safety of the patients the residents are caring for, safety for the patients they're going to care for after they complete residency program, and also assure that we have a humanistic and educational environment for the residents. And again, we're looking at a July 1, 2011. You can't tell I'm a little anxious about this July 1, 2011, can you? Basically, if we look at what their recommendations were, they focused on education and work environment. Now, there were a lot of changes in the educational piece, new requirements that we have to meet, new things we have to teach residents about. Major thing that they're saying is you got to take education from the classroom and get out to the bedside. So there's things we're teaching didactically, we've got to find a way to actually teach them at the bedside as well. They want us to monitor what we're teaching, and they want us to have outcomes data to show that if there's an expectation that by the end of this rotation the resident will have achieved skill X, how do we know that the residents achieved skill X? And how do we know that our teaching methodologies are actually helping him or her to do those? And they also, in the work environment, focus primarily on duty hours and supervision. So let's talk a little bit about the educational recommendations. They are all focused, I don't care how they're labeled in these common program requirements, they're all focused on patient safety. Big buzzword in healthcare, ACGME has picked up on it, everything's really focused on patient safety. So they want us to educate the residents on professionalism. We want to make sure that they understand that sometimes the needs of the patient are going to supersede their own personal needs, and maybe you need to stay over an extra hour as opposed to leave when it's time to go. They want us to integrate residents into interdisciplinary teams, concept being that right now the physician is not a solo practitioner. The physician is a member of a team, and residents need to learn how to work effectively within those teams and also look at patient safety and quality improvement issues. Heavy statements about no reliance on residents to fulfill non-physician service obligations. This is not new, it's just a refocus. And then as Jim talked about the patient-centered care movement, they want to ensure that we're training residents in environments where patient and family-centered care are focused. They want us to formalize transitions. So if I'm a resident, I've been on 24 hours, I'm handing off my patients to you, they want to know that the pertinent information, necessary information is there, not just the lab values, but also maybe some impressions that I have about what needs to have with this patient, what's concerning me about this patient. So we're in the process right now working with Tom Hubbard and Paul Hakeem, and they've got a project going to try to formalize a transitions process for the medical students. We're kind of piggybacking on with them to ensure we've got a longitudinal process. They also want to make sure that when residents and attending faculty members are on a ward, that the other healthcare members and the patients know who's the teaching faculty, who are the residents, and what are the roles. We have, for probably 10 years, been required to teach residents about fatigue and its impact on clinical care. Now they want us to start teaching residents about mitigation processes. How do you keep from getting tired? What do you do if you are tired? So we have to teach about strategic napping. We have to develop backup call to ensure that if we identify a resident that's got a problem, we can send somebody in to take over his or her patients. They also want us to teach them about judicious use of things like caffeine to help mitigate the fatigue. We're also required to provide adequate sleep facilities, not just call rooms for overnight, but if a resident's coming off call and is too fatigued to drive home, we've got to have a place that he or she can go to sleep until they are ready, or we have to provide taxis or buses or something. One of the charges that we're going to have is how do you know if a resident can drive or not? So we're trying to come up with some way nationally to look at how do you determine that a resident's safe, that a resident is awake enough to be able to safely drive home. All right, supervision. If you look at the studies on malpractice claims involving residents, 60% of them are attributable to lack of appropriate supervision. So we got residents out doing things that they're not ready to do without me or the physician, the supervisor standing next to them. And again, this goes back to that sole focus on residents or learners. They're not healthcare providers. So for the first time, ACGME is going to define supervision for us. It used to be they just said, go out, supervise them, you know what you're doing. Now they're going to tell us exactly how we're going to supervise them. And that is for PGY1 residents, when they first come on service, there has to be a faculty physician in the room with them. And you have to have a way of measuring when they're ready to be supervised with what they're talking about indirect with the direct, which is that now you as the faculty physician don't have to be standing next to them. You can be down with another patient, you can be in the OR, you can be down in the lounge. You have to be within the facility. Then that next transition is, well, okay, it's indirect, you can be at home, a phone call away, and then we get to the point where it is the oversight, which is where they're available to provide consultation and review the patient care afterwards. So this is brand new for ACGME. They also decided that they were going to change our duty hour requirements. And basically what they've done with these duty hours is they're turning the pyramid where your PGY1s had all the call, or not all the call, but a lot of call, and as you moved up the educational ladder, your call became less intense and less frequent. They've actually turned that around. This is part of the revolution that NASCA is talking about. So what have they done? If you look at continuous duty hours, right now, a resident, regardless of the level of training, can be on continuous duty for 24 hours with an additional 6 hours for handoff of patients. As of July 1, our PGY1s have continuous duty hours limited to 16 with no transition time. So you can see there's a huge difference in terms of the number of hours that they can work now and the number of hours July 1. PGY2s and up stay with the 24 hours of continuous duty, but those 6 hours for transitions become 4 hours. So we don't have to sit here and do all the mathematics, but you can see we've probably got a substantial impact upon the available personnel to provide that care. So Jim and I have been going around and talking to the program directors, the chairs, the office managers, and the residency coordinators, trying to get them to look at what these changes are going to do to the patients we provide care for. We're also having to do some manipulations, obviously, on the educational program, because what you saw in 24 hours educationally, now we're going to have to cram into 16 hours. So it's fairly substantial. So what have we done to join the revolution? Well, obviously, we came back with the common program requirements. We're doing educational programs with talking a lot about it, the Graduate Medical Education Council, which is our management structure. Gone to a lot of meetings. We had a statewide duty hours forum in Richmond, which we had all the all the programs that sponsor residency programs around the state attended. We're increasing the involvement of our hospital partners in our educational process. We asked Paul Chittister from Centerra to join our Graduate Medical Education Council so he can hear what's going on. We have developed some subcommittees within the GMEC to start addressing some of these issues, and as I said, Jim and I have been working with the programs. Now, I tend to think in songs a lot, so as I started looking at what's happening in GME, this lyric from Don Henley kind of hit me, which is, the more I knew, the less I understood, and all the things that I thought I knew, I'm having to learn again. And I think that's going to happen with our program directors and faculty members too, because it's a whole new day in terms of how we view and interact with resident physicians. Dr. Nasca kind of left us with this quote as we walked out the door, in addition to the other one about denying that change was coming, was that somebody has to do something, and it's just incredibly pathetic that it has to be us. So that's kind of what we're in the middle of. Are there any questions? Yes.
Is there any talk about extending the length of residency programs in order to cover the amount of hours we're losing in patient contact time?
Yeah, that's a conversation that's going on a lot of levels. The variables they're concerned about, obviously, is student debt. Looking at, we've also got a limit on the number of GME positions that are paid for right now through the federal government, which is the payment mechanism, and that we're looking at, I think it's 2016, with the increased medical student class size, the number of positions and the number of available medical students is going to cross, so that we won't have enough positions. So the payment structure from the federal government, combined with the debt load of medical students coming out, has kind of kept that conversation from going too far, but it is definitely an issue that's on the table.
Good morning. For anyone who doesn't know me, my name is Mark Babashanian. I'm the Vice President for Administration and Finance, and it's the administration part of my title that leads me here today to talk to you about our construction on our campus. Many of you have heard me talk about this over the last year and a half. The good news is we're getting close, okay? August, September, we'll be through with all this work, so please bear with us a little bit longer. I'm going to make this fairly brief, but you can obviously ask me questions anytime you want. We'll start with new building timeline. New building is thankfully running ahead of schedule. It's also on budget, but it's ahead of schedule by a couple weeks. We're going to have our first people move in the end of June, which is close to a month ahead of our schedule. We'll have everybody moved in by August 5th, but really most everyone will be moved in by the beginning of July. So that's way ahead of our schedule, and we're very happy about that. The Brickell Library, we're ahead of schedule there also. We've already moved the computer classroom and the lab back down to the first floor. Next Monday, or this coming Monday, we're going to move the circulation desk back down to the first floor. Will allow us to finish our renovations on the second floor to the student study spaces, and the students will be able to get out of their portables that they've been in and back into the Brickell Library second floor to study on April 4th, and that is also a month ahead of schedule. And we're very happy about that so that we can do the best job we can with the students. Lewis Hall, this building, we're also ahead of schedule substantially. We're going to start moving in one group at the end of this month. Admissions is going to come back from Smith Rogers Hall onto our campus here into Lewis Hall at the end of March. The rest of the administrative spaces and the student space will be open in July. Brick replacement, which as many of you know has been the most problematic of our issues, the noisiest of our issues. It's basically on schedule. We have made several changes in the phasing of doing the brick replacement, in particular to not do brick replacement right outside of this room and the Roper Lecture Hall when students are in here having lectures or taking exams. So they've stayed away from this area. When spring break comes the end of this month, they'll hit this area with a vengeance and then be out and finish up elsewhere. So that'll also be through, though, by the end of July. Parking, if y'all remember, we've talked about the staff garage expansion. That is also running ahead of schedule just by a couple weeks. We'll be opening in a week or two the visitor portions, 2nd to 7th floor of the staff garage. The first floor, which is for visitors, I might have said that wrong. We're opening the 2nd to 7th floor for staff. The visitor section, which will give us another 80 spaces right behind Hofheimer Hall, still scheduled to open by the end of this month. Which brings me to something that we haven't talked about as much, but it's coming. This is the changes to our campus roadway infrastructure. Okay? They're going to start by the end of this month. And this is a slide I have. I'm not going to dwell on this much, but just to say a couple things, that the visitor garage entrance and exits are going to change. They're going to go off Wagner Road. We'll have green space here where there is currently visitor lot parking, okay? It's going to really enhance the look of the campus. The changes to the roadway infrastructure will make this campus much safer for not only automobile traffic, but especially for pedestrian traffic. Timeline for this is still being developed. The contractors were just hired earlier in this month. They're hiring the subs right now. We hope to get them working on the ground by March 16th, for sure by before the end of the month. Our new target is September 22nd to coincide with the grand opening of our new building. We're going to do everything we can to meet that deadline. We do have to make sure that the contractors agree and can get that done. So in a nutshell, that is, those are our timelines and how we're doing. Appreciate all of y'all's patience as we've been through this process. The noise will now start to move outside into the streets. It's going to be, actually, I think I have one more slide. This is going to be not easy, okay, on the streets, just like it wasn't easy in these buildings. But we will always have one lane open, at least. We'll have traffic people there, not only from the construction team, but our own police and public safety people will be out helping monitor and direct traffic and pedestrian traffic. But there will be delays, so please plan ahead and prepare for that. We'll do the best job we can to provide adequate signage and to get you directed around the streets. Some sidewalks may close for some periods of time. Again, we'll do the best we can there to give you notice. So with that, I'd be glad to answer any questions if y'all have any. Okay, well, thank you very much. I will now turn it over to President Lester.
Well, thanks to our three presenters today. I appreciate your listening carefully. The world is changing, folks, including our own little world right here. And if you live until August or September, it's really going to be a good place to do business. So thanks for putting up with the construction, and get ready. The road thing is going to be a nightmare. But I promised everybody last night, and I'll promise you, by September, we're going to be totally out of money, so we won't do anything for a while after that. The dean search continues. To recap, last winter, the dean told us he was ready to move back to his old job as chairman of physiological sciences. We messed around until summer. We hired a recruiter. August, we put together a search committee. That committee looked at a number of candidates through the fall, interviewed several, and as of the first week in January, I began negotiations with one of the candidates that they recommended. As of a few days ago, we agreed that that was not going to work. The candidate that we were, that was very qualified, that we were hoping would move into the dean's position, had interest in being the president, and we had interest in that candidate being the president, but our timetables couldn't coincide, and so ultimately we just decided that we need a dean, and we'll back up and start over. Actually, not really start over. Another of our candidates, well qualified, will be on campus next week for some further interviews, and the search committee will meet the following week, and we'll see where we go from there. So the dean assured me when I got this job 6 years ago that I should learn the pace of academia because it's different than the rest of the world, and things that you think can be done in a fairly short period take time. So it is taking time, but we're all okay. Be happy to answer any questions about that or anything else. Or, last chance, 3 smart people up here that have that made their presentations. Anything else on anybody's mind? We are going to continue to do this from time to time. I mentioned at the beginning of the hour that we may try one at the middle of the day to see if that's a better time period. Look around, folks. There are 1,500 people that work here. We have almost 1,000 students, and we don't have a very good showing today. So tell your friends, if you enjoyed what you heard, tell your friends, and we'll do something good next time. But not hearing anything, I'm going to say have a great day, and thanks for coming. Bye-bye.